patients that lack more epinephrine, that have decreased concentration, psychomotor retardation, loss of vitality or lethargy, fatigue, or decreased self-care because they are lacking good motivation. Now, how do we select treatments for depression? There are patient factors, there are medication factors. So we want basically to see what symptom domains the patient has, do they have comorbidities, do they respond to treatments, and also do they deselect certain side effects? Are they upset more about side effect A or B? And can we select medications based on that to fulfill patient preference? Because if we don't, they will put their feet and stop the medication. But there are also medication factors. Are they efficacious? What's the relative efficacy in network meta-analysis? What's the safety? Are there interactions with other drugs? How simple are they to use, and are they available? Now, here are features why sertraline can be a helpful drug. Sertraline, known to many of us, also liked by many of us, because you can, I like it a lot for one feature, because you can go very, very slowly. Yeah, to 200 in OCD, 300 milligrams, and you can half the 25 milligrams, 12 and a half. So 12 and a half of 200, that's a lot of steps you can go on. Also, there's approval for depression with anxious distress, melancholic features, atypical features, seasonal pattern, cognitive dysfunction. And sertraline does very well in meta-analyses and has, on the other hand, adverse effect system profile, and there's very little drug-drug interactions. It's pretty unaffected by inhibitors of this cytokine-controlled system. Now, we mentioned already that depression and physical disorders can often co-occur. This is the diabetes and depression study, or depression and diabetes study, where at baseline, patients have quite a bit of depression. And you can see that in those patients that have diabetes, which is a chronic disease and can weigh down people, associated also with inflammation and obesity, here sertraline was significantly better, not than placebo in the long run, but than CET. So yes, you can use psychotherapy, and it seems to work when you give the psychotherapy at 3 months, similar as the antidepressant, but then you stop with the CBT and people worsen again because they may not apply all their skills, but if they apply the medication, there is no loss of efficacy over time. When you have physical disorders, you may not want to worsen some of them as a side effect of the medication. So here we have the SAD heart study, where patients on sertraline, actually in patients with myocardial infarction or unstable angina, did not worsen any of the physical parameters that already can be problems in people with heart disease. At the same time, sertraline helped the depression. Looking again at cardiac risk factors post-myocardial infarction, there was actually a significant improvement in heart rate variability. We know that heart rate variability is important when it's constricted, like here with placebo. The risk of having a heart attack or even an arrhythmia is higher. So we need to actually restore this variability and not reduce it like placebo. And the same is true for treatment of platelet factors, which basically, when you have too much of this, then you can create thrombi that obviously can make it hard for the heart or the brain to work. So here, reducing platelet factors is a good thing, and sertraline was able to do that significantly better than placebo. So here again are the choices you have here. SRIs, NRIs, and maybe part of personalized medicine, part of preventive and personalized psychiatry is to pick features of your patients, pick features in their disease in order to optimize care. Depression is a feeling, but many of our patients that means they are not moving around. They are not doing things. And that often, when you ask patients why that is the case, has to do with feeling fatigued and loss of energy. So depression sucks this out of your personality. Not only is the joy gone, it's also the energy gone. And that's very common. 73%, almost 2/3, felt tired, felt fatigued. And there we need to also help patients, because if they still have this fatigue, they will not be able to go back into rehabilitation. And when you do something that makes sense and gives you self-worth, you also improve depression. But if you can't even bring yourself to do it, it's a problem. So here's effects or XR. So we have amorphexin, which is at low doses, and SSRI, and at higher doses, dopamine, very high doses, dopamine kicks in, and at medium and high doses, noradrenaline kicks in. And here you can see that energy improves because you're increasing the juice, you're increasing the noradrenaline. And that change happens as early as week 2, both in terms of energy on the left and lassitude on the right. These symptoms, actually, that we're talking about are quite persistent. In the middle, you see, yes, depression improves over time and stays down, but what towers it in terms of persistent symptoms is really cognitive problems, again, slowing down, lack of energy, and sleep problems. So the lack of energy is very, very close to the most important or the most prevalent symptom of cognitive problems. You can measure other elements that are cousins of fatigue and lack of energy that actually have less of this drive component, but also an experiential component. Anhedonia means you don't enjoy things anymore that you did enjoy. Amotivation is you can't bring yourself to do things. And there are different items on the MADRS, 5 here in the middle, that you can see that load on anhedonia, and there are 3 items on the MD that load on amotivation. Clusters of amotivation are gaining a lot of interest. There are new medications with new mechanism of action, like for example the kappa opioid receptor antagonist, that focus particularly on anhedonia and amotivation, because these patients have a hard time functioning well. So here you see how you actually define elements of amotivation. It has to do with general somatic symptoms, but also apathy can be evaluated, which has to do with goal-directed behavior, goal-directed cognitions and responses. Do you have hedonic capacity, meaning that you can enjoy things? Do you have reward expectancy in learning? What about being able to evaluate it's worthwhile to put my energy into something and then make the right decisions? And here you see that amotivation is really very relevant. It's related to the ability to work, manage things at home, have social activities, leisure time activities, and relationship, all significantly associated. And also, amotivation is negatively correlated, meaning more amotivation means less subjective quality of life, and also less overall satisfaction. Anhedonia is a little bit different than amotivation. Motivation has to do with appetitive behavior. Do I want to go for something? Anhedonia is when I'm there, do I care? And here you can see that you can bring that also into different subdomains. It's either do I anticipate that something will be great, so that's why I go for it. When I'm there, do I enjoy it? And then also, do I make the decision to go there or not? Anhedonia is an important predictor of disease progression, so when that doesn't improve the ability to have joy, it's an A criterion in depression. That means there's higher severity of major depressive disorder, the disease will be prolonged, There's a worse long-term also functional prognosis. And unfortunately, when you don't treat anhedonia, when people feel blah, they also say, why am I here? I can't enjoy life anymore. And suicide rates are high. But there is hope. There is treatment. Here you see that again, a drug that can enhance noradrenaline, then Naproxen or Effexors are as early as week 2 on the left-hand side, looking at the 5 MADRS items, can improve elements of anhedonia, significantly so, week 2 onwards, out to the last week in the study. And on the right-hand side are the 3 items on the MVP, on the HANDI, that also tap into anhedonia. You can see again, as early as week 2, there's statistically significant improvement of this key feature of anhedonia that really decreases quality of life and functioning, and also keeps people chronic when they go to rest. There's another analysis that looks here at the anhedonia scale, and you can see when pooling together studies and looking at the MADRS as early as week 2, anhedonia improves significantly better than the placebo. Amotivation, we talked about it. Again, it's more this additive behavior. Here again, as early as week 2, when pooling together the studies with the effector, you find improvement in amotivation. So people can do things better, and even if they may still be depressed, as you do something that's meaningful, your depression also improves. So it's very important to beat the amotivation. And then we also, coming back full circle to what we talked about before, we have depression with comorbid headache, back pain, shoulder pain, overall pain. Everything is a pain when you're depressed, and that can interfere with daily activities. And also, you have a measure of overall time while awake. And you see that at baseline, all these bars have a higher rate and higher rating. So patients before treatment really suffer. And then Effexor or Naproxen XR is given, and there's a dramatic increase. So for overall pain, you cut this in half, you cut it to maybe 2/3 for headache, back pain, and shoulder pain. You halve it again for interference with daily activities, which is the holy grail. We don't want to only improve symptoms, we want to improve people. And people are defined by what they do, as daily activities. And the overall pain also goes down to 2/3. So what are patient profiles when we have different antidepressants available to us? So there is, for example, the sertraline, approved in multiple anxiety disorders plus MDD, shown to prevent relapse and recurrence of these disorders. Also has been shown to not worsen conditions in people with medical comorbidities that are very common, but even rather to improve things so that patients might be able to live a life that is better tolerable. Psychiatric comorbidities can improve as well as medical comorbidities. And sertraline can be helpful at extremes of age because, as I mentioned, you can dose in very small increments. In women also, there's very little interference with other medications, and also maybe it's more important to have a woman who is safe and a woman who is healthy to treat or to take care of their baby both antenatally by going to natal care and postnatally, than not having antidepressant during pregnancy. You're not exposing patients to an antidepressant, but you may expose the growing life to inflammation and depression, and that can also be transmitted. So it's obviously shared decision making what to do when you're pregnant, but stability is key. And what about profiles for The more severe the illnesses, maybe you want to have a dual reuptake inhibitor or triple reuptake inhibitor. You want to prevent relapse. It's not only good for depression, it also works for anxiety, and it's quite effective when you have comorbidities. And when you have those symptoms where you want to turn on the juice. Patients that have comorbid or key features of depression or fatigue, amotivation, anhedonia, problems with cognition, and somatic symptoms, one of the areas we're talking about tonight. So let me conclude to give us time for questions and catch us up on time. Somatic symptoms are extremely frequent and can also be an expression of symptomatic depression. But somatic symptoms can also be their individual disorder, and that disorder, if it comes with somatic problems, might then lead to depression. So we need to always treat both the underlying condition and then maybe the secondary depression, or realize that the depression looks like a physical disorder, but it's masked by the somatic symptoms. We need to screen for unexplained chronic and exaggerated symptoms. We need to make sure we understand that anxiety and envy can co-occur, and that anxiety is a very physical occurrence, which may then be misinterpreted as a physical disease. There might be fear of having a physical disease. Fatigue and anhedonia are features that at the end are important for functioning. And we need to select antidepressants according to surely efficacy, but also tolerability profiles. And here we have a good choice when surgery is given in people with physical comorbidities, and maybe venlafaxine for core MDD symptoms, including amotivation and also fatigue or having problems with anhedonia. So I thank you and look forward to some questions.